Hi, everyone, and thank you for joining our webinar today. We are focusing on what everyone needs to know about infantile spasms. I'm Dr. Kathleen Farrell. I'm the Vice President for Public Health and Outcomes at the Epilepsy Foundation, and I'm joined by three wonderful panelists. Dr. John Mytinger, the Associate Professor and Director of the Infantile Spasms Program at Nationwide Children's Hospital and The Ohio State University. Julie Oberlander, mother and advocate, and part of the Duke 15Q community, and Jackie Steinberg, mother and advocate, part of the STX-BP1 community, and she serves as the scientific liaison with that foundation's board. This webinar is being hosted by the Epilepsy Foundation in partnership with the Rare Epilepsy Network, REN. Our learning objectives for today are to learn from personal experiences of families affected by infantile spasms, to emphasize the clinical manifestations of infantile spasms and the importance of timely recognition, diagnosis, and treatment, and to share resources, knowledge, and supports. Your questions today are very welcome, and we'd encourage you to please submit questions via the Q&A function in Zoom. You'll see that button for Q&A down near the chat box. With that, Dr. Mytinger, you're welcome to begin.
Thank you, Kathleen, and everyone from the Epilepsy Foundation. It's an honor to be here with everybody, Julie and Jackie. It's an honor, and it's going to be a great conversation. And best of all, we get to talk about these miracle kiddos that you have. So for my part, I'm going to talk about infantile spasms in regard to recognition and the importance of what is called standard therapy. Okay. Next slide. Okay, infantile spasms are seizures, and they need to be treated quickly. So it is an urgent diagnosis. Ideally, we start treatment soon after the infantile spasms start. We don't think of these seizures as causing brain damage. The way I think about it and explain it to families is once they start, there is a period of time in which a critical period of development is being missed. And so we want to return children back to their developmental trajectory as soon as possible with our urgent treatment. Next slide. Just a few things to know. It's about 1 in 3,000 children develop infantile spasms. The onset most commonly is between 3 and 12 months of age. In fact, that occurs in more than 90% of the time. And there's a peak at about 6 months, so that's important. They can occur later in life, but they become rare after 18 months. And there are numerous causes with a final common pathway to infantile spasms. Now, the outcome, and I'll talk about this in just a second, is strongly determined by the cause of the infantile spasms. But treatment plays an important role in outcome as well. Next slide. Okay, here are just a few of the hundreds of potential causes for infantile spasms. So, for example, a brain injury, things such as a stroke or lack of blood and oxygen at the time of birth, brain infections. Sometimes the brain doesn't form normally, and we call those brain malformations. There are a host of genetic problems such as Down syndrome or trisomy 21, and so many more. And we have an important classification called unknown. And so that's a situation in which, despite our best efforts and doing our testing, we can't figure out the cause of the infantile spasms. And that's okay, because particularly if those children have normal development leading up to infantile spasms, those children tend to have the best possible outcome. In terms of means of figuring out what the causes are, the best test, after an examination, is the MRI, a brain picture, and that often enough gives us the cause of the infantile spasms. And the next best test is genetic testing, and there's a host of other possible tests as well. We need an EEG as well, and I'm going to talk about that in just a second. Okay, so this is how I explain it to families that I see. So there is a brain problem. Let's imagine it's some kind of injury. And that leads to a less than normal outcome. So, for example, what a child might look like when they're 5 years old will largely be determined by what's going on with the brain problem. Next slide. So what can happen is during infancy, these seizures can come along, and this really abnormal EEG, a chaotic, disorganized EEG. An EEG is an electroencephalogram or a brainwave test. And so we have these two things that come along, and they make the outcome worse than they would have been just based on the cause, the brain problem itself, okay? Now, we typically can't treat the brain problem. Next. But we often can treat the seizures and the abnormal EEG. And I'm mentioning this here, the importance of eliminating the infantile spasms if possible, and also improving the EEG in a way that's clinically meaningful, meaning that we get it as close as we can to normal. So those two things have to happen for best possible outcomes. Next. What are the outcomes? About a third of children, or I should say up to a third of children, can have early death. And most of the time, that's related to underlying brain disease, medical problems. And very rarely would it be associated with the treatment nowadays. So about 1 in 5 children will relapse after we initially get them into remission. About half of children have other seizure types that we have to watch out for. About 1 in 5 children or so will develop something called Lennox-Gastaut syndrome. So that's a situation in which infantile epileptic spasm syndrome, as an infant, can evolve later in childhood to this very difficult syndrome with multiple seizure types, difficult to control seizures. About 1/3 of children will have autism, and that's particularly true in children who have tuberous sclerosis complex as their cause. About 1 in 5 to 1 in 4 will ultimately have normal intelligence or mild intellectual disability. So most children have significant degrees of intellectual disability. Next. However, great outcomes are possible. And so this is a child that I had treated early in my career. We treated her within about 7 days of infantile spasms onset, and her outcome was amazing. She has normal intelligence. She's very accomplished, and so this was just a really, really great outcome. And for children who do have, and in this case, for example, she had no known cause of her infantile spasm. So again, as I mentioned, that can be a good thing. But even for children with a known cause, we can achieve improvements with treatment, with early and effective treatment. Next. Okay, so part of what I want to do is to raise awareness on how we might identify infantile spasms. So here are a few pointers. They almost always occur during wakefulness. So typically the eyes are open. Most often, there are certainly exceptions. They often do occur on awakening, so whether from a nap or a night's sleep, so that's oftentimes when you see them. And it can be any really combination of flexion, extension. It can involve the neck, the trunk, the arms, and hips. And there's some other features I'll talk about in just a minute. And then this clustering is so helpful for the identification of infantile spasms. So one after another, and a cluster can last several minutes. And I'm going to talk more about that on the next slide. So this is Aubrey, and we're going to learn more about Aubrey in just a second. But here she is at 6 months old. And what I want to go ahead and play the video. And what I'd like to point out, these are very classic infantile spasms. This crunch at the abdomen, oftentimes the reaching out of the arms, and the flexion at the hips. The things that we often don't think about because of all these movements is there's often a very distinct quieting of behavior. Okay, so there's a quieting. You can see that in Aubrey. She's kind of very quiet and still, almost as if she's waiting for the next infantile spasms. And then here's the key that I really utilize a lot in my practice is the interval between each infantile spasm. And that interval is very often, go ahead and hit the next. That interval is very often, perfect. And so what I'm showing you here, each red line is an infantile spasm. And between each infantile spasm, there's an interval. It's not perfectly regular, but it's fairly regular. So we use this feature to help identify infantile spasms. This is very typical, this interval between spasms. When I review a video of a child who has movements that are very rapidly repetitive, without getting to that at least a few seconds interval, I can pretty much say that, okay, that is not an infantile spasm. And we look for other things that I've already mentioned as well. So, okay, so we'll go ahead and move on from here. Next slide. How about there's an entity called subtle spasms, and that causes some difficulty, including misdiagnosis. And this could include just mild contraction of the abdominal muscles or subtle movements at the shoulders, the lips, or the eyes. And these are often dismissed as normal baby movements or reflux. So we have to be on the lookout for these things. Go ahead, next slide. But we can use the same principles that I've already talked about. So take this little girl, 7 months old. She has some very subtle infantile spasms. Go ahead and play the video. She had an in utero stroke, and so that put her at risk for the development of infantile spasm. That's certainly what happened here. What I'm showing you here is some subtle facial movements. And so there's a downturning at the mouth that occurs. I call that retch sign because it's almost like the facial features of a retch, like right before you vomiting, before vomiting. Now, vomiting doesn't occur, but it does have the facial appearance, in my view, of a retch. Often in these cases, the eyes can't fixate or the eyes roll up. Not as impressive here, but you can see, go ahead on the next, if you hit next, you can see this downturning of the mouth. And I do look for that. Other things can cause that, but if they're occurring at regular intervals, like I mentioned, with the interval being about 3 to 30 seconds, we really have to think, hey, these might be infantile spasms. Next slide. Yeah, the interval, as I mentioned, 3 to 30 seconds, same as before. Go ahead. Okay, so we'll go ahead and play this video, and I want you to test yourself at home. Are these infantile spasms? So first of all, are these typical movements? Is there a quieting? And is the interval typical for what I've described, 3 to 30 seconds? Let's just watch one more. So there you go. And so go ahead and hit next, and we'll talk about this a little bit more. So you can see their interval is very typical. And these movements are typical for subtle spasms. You can see this downturning at the mouth, the retch sign. There is a quieting type behavior within this cluster. And again, the interval is so key. Okay, next. There's that retch sign that I mentioned, the downturning at the mouth. Next. Okay, so these are the standard therapies. I'm showing you this because if you have a child who has infantile spasms, these are the therapies that should be offered to you. Okay, so there are 2 therapies that are categorized as hormone therapy. One is adrenocorticotropic hormone, or ACTH, and another is high-dose prednisolone, okay? One is FDA approved, one is not. That doesn't mean that one is inferior to the other. In fact, in my experience, the effectiveness of these 2 hormone therapies are similar, okay? One happens to be very expensive and somewhat difficult to get initially, and then the other is readily available. You can get it at any pharmacy. It's quite inexpensive. So in my practice often is the case that children start high-dose prednisolone right away. We get the treatment started. If children don't respond to that treatment, then I think about the second treatment, which is often either vigabatrin, which I'll talk about next, or ACTH, okay? And all 3 medications can be used as first, second, and third treatment. Just because you don't respond to one hormone therapy, you may respond to the other. Okay, so vigabatrin, also a good medication. It is also expensive. It is FDA approved. Next. Okay, just a few things about hormone therapy. It really should be your first treatment in those eligible to receive it. The situation in which that's not the case is if somebody has tuberous sclerosis complex, those children should receive vigabatrin first. Common side effects for hormone therapy, irritability, very common. Children become puffy, they have water retention, their appetite goes up, so there's weight gain, poor sleep, constipation. These are the things I see commonly. Serious side effects with contemporary dosing. So 2 weeks at a high dose and weaning over about 2 weeks, roughly. The risk of serious side effects are low. Very rarely would there be a death due to immunosuppression? That has become very rare in contemporary management. Next. For vigabatrin, it's a great second or third treatment, unless again it's tuberous sclerosis complex as a cause, and there you want to use vigabatrin as the first treatment. Common problems are sleepiness and decreased muscle tone. Very rarely would there be issues related to a detectable peripheral visual field loss, as the retina doesn't like the vigabatrin over the long haul. It's not something that I would see commonly in my practice. And I just mentioned here, topiramate is not a standard therapy. So if you have a child who has infantile spasms and you're offered topiramate as the first treatment, that is not the right choice. And you can tell them that Dr. Mytinger said that there are 3 standard therapies, and this is not one of them. Okay, so in conclusion, I'll ask you just to remember that clustering that occurs at fairly regular intervals between 3 and 30 seconds. Have somebody who knows about infantile spasms review the video. Watch out for children who have known brain disease, clustering spells, often around 6 months or so, and the importance of early standard therapies, prednisolone, ACTH, vigabatrin. They should be used and can improve outcome. And your clinician should really be thinking about, okay, if this is not working within about, say, 7 to 14 days, somewhere in there, you really want to be thinking about transitioning to the next one. So that's all I have. Thank you so much.
Thank you very much, Dr. Mytinger. Julie, I will move to you next.
Hello, good morning, good afternoon, everyone. My name is Julie. I am an IS mom. Thank you so much to Dr. Mytinger, who is my daughter Aubrey's neurologist, and to Kathleen for inviting me to be here. My daughter Aubrey was diagnosed with infantile spasms back in 2019 when she was 6.5 months old. I have zero medical background and I'm not an expert on any of this, but I'm really thankful for the chance to just be here and talk about my family and our experience with IS from those first few terrifying hours and days, how we learned about having to advocate for our kid and to share the awesome successes that she continues to have. So I'm just going to get right into it. It was a Sunday. It was July 21st, 2019. I was getting Aubrey and her older brother ready for a family cookout we were going to. And as I was getting Aubrey dressed, I noticed she did this like strange thing with her arms where she kind of like lifted them up a few times. And I was like, that was weird, but didn't really think anything of it. We were then in the car driving and I just couldn't stop thinking about those weird arm movements. So I called the after hours nurse line and explained, like, it seemed like she was startled by something. So they asked me the typical screening questions like, does she have a fever? Is she constipated? And I'm like, no. So the nurse said, well, maybe it's her hearing and she really was just startled by something. So, okay. But that night it happened again. This time I captured a video, which is the one Dr. Mytinger just shared previously. And I called her pediatrician's office the following morning. They said, well, just watch for it. If it happens again, maybe call us. Maybe she should come in and be seen. So it did, and I did. Took her in. I took her Tuesday morning then. Armed with my iPhone video, I showed her pediatrician, and he ended up sending that video down to the hospital's main campus for review. And he sat with me and he calmly explained, I think it's probably good to have a few more tests done. He said, he didn't mention the word seizure, but he did say, go home and pack a bag and then go downtown. He said, I'll call ahead, let them know you're coming. You need to be admitted. And I later learned that when he was a resident, he had actually seen one baby that had IS, and he remembered those tiny little spasms. He remembered what they looked like, and he knew, you know, what Aubrey needed. Next slide, please. So now it's Tuesday, the 23rd, and we are in the hospital. Aubrey starts on an EEG and an IV. Within a few hours, a doctor sort of casually strolls in and she said, hi, Aubrey has infantile spasms. And she handed me a printout from epilepsy.com, which was a great piece of information, by the way. But maybe wasn't exactly the best delivery for a terrified mom and her baby hooked up to all these wires. So we spent a few days in the hospital. Aubrey did start on prednisone and we did an MRI. Thankfully, MRI came back normal. And we were sent home. It was another week or so before we came back for more EEG. And by this time, my husband and I really started to do our own like frantic research, and we were realizing how serious this could be. And my husband came across a pediatric epilepsy advocacy group called Mickey's Miracles. And he was like, we should call him, and I wasn't sure right away. So we did. We called and Christy answered right away. And for lack of a better word, she yelled and she said, you need to get better, faster, immediate treatment for Aubrey. This is an absolute medical emergency. And I was, of course, shocked to hear this. And at that point, we figured out that this might mean us having to advocate and like do something about this. This is all very new and scary for us. And typically I don't do confrontation, but we were thinking about the situation we were in, and at the hospital, there was nothing said, no one said anything about an emergency. There was no treatment that was had the feeling of urgency at all. And we then learned about these frontline drugs like ACTH and vigabatrin, and we knew we had to get them for Aubrey, whatever it took. Next slide, please. And if we could just pause for a moment. I just really want to share 2 quick videos just so you can see how subtle these spasms can be. I'm sure a lot of families out there have seen this, but and unfortunately they're familiar with these, but you can see how easy it can be misdiagnosed or not diagnosed at all. And the first video you saw of Aubrey was very typical with the crunching, but they changed and they ended up being super subtle, just like little, subtle baby movements. Could we play the first one, please? And then the second one, please. So super subtle, and babies do weird things, but like Dr. Mytinger said, the repeating, the cluster with Aubrey, those will last a couple seconds and maybe 10-second intervals, and then they would last for about 2 minutes. That's in her case anyway. So now we're back at the hospital. The doctors tell me that they're not sure it's IS and they were going to try Keppra. So after a couple more days in the hospital, we are panicking, and there was sort of a turning point for me when the neurology team explained that those meds we asked about were really expensive, they might not work, and they were hard to get. And the team looked at me, the mom, and said, what do you want to do? And I just knew that like this wasn't the care team that we could stay with and feel comfortable with. And thankfully, we had been connected with Nationwide Children's Hospital and Dr. Mytinger, and we saw him just a couple days later. So now it's August 7th, and he was immediately able to diagnose the IS and got her on the meds. And we left Columbus that day with a whole slew of emotions. We were devastated to get the diagnosis, but also super thankful that we had something to do, something to go off of, and we were getting the treatment that she needed. Those meds were hard. They were hard to get, but we got them, and she gained tons of weight. She slept nonstop, and she didn't smile for about a month, which was really hard to see. And then ultimately, unfortunately, she did fail the 3rd and 4th meds. The spasms were still happening, and Dr. Mytinger made the call to put her on a 5th med, which was Zonegran, at the end of August. And we just sort of hoped for a miracle then. We moved on to discuss potentially the keto clinic, but that was sort of it. It was August 29th, and that was the last seizure that Aubrey had, at least that we have seen. So it's pretty amazing stuff. So it was about a year to wean her off of all the medicines, and slowly but surely her personality came back, and it's been over 4 years and she's doing phenomenally. We also did genetic testing and learned that Aubrey has a rare genetic syndrome called duplication 15q syndrome, or DUP15q for short, which is an extra chromosome or part of chromosome number 15 that can cause seizures, developmental delays, and other various symptoms. But Aubrey is a force to be reckoned with. She, at 10 months old, she was not sitting or even rolling over. We started her in all the early intervention programs here in our county, which seemed crazy to me at the time, but it was amazing. She did speech therapy, OT, PT, pool, all the things. She started walking at 2.5 and talking at 3.5, and she literally hasn't stopped since then. We celebrate her inch stones. She does have a global delay, but she is making progress. And one of the best pieces of advice from Dr. Mytinger was to treat her like a typical kid as much as you can. And we're really trying to do that, especially with her older brother as a mentor for her. And then, oh, sorry, next slide, please. I think I skipped one. This is her this summer jumping around and singing. So here you can see in the September photo is full dose ACTH, very swollen. September 20, she started smiling again, and that's her on her first birthday, a happy little 1-year-old. And we can go to the next slide too, please. So here's her doing her PT work and hanging out with her brother, and just a happy kid, and just living and full of life. But if I had to sum up this experience, I guess in one main thing I learned is to follow your gut. You know your kid better than anyone. And if you feel like you don't understand something, or you're not being heard or getting the care your child needs and deserves, do something about it. Ask questions, demand answers. It's also amazing to have a network of families that get it. Doctors are amazing and really smart and really caring, but the families are the ones that are there in the trenches. They're giving the shots, they're up all night, they're watching for seizures. It's just a whole thing. And having someone in your corner that, speaks that language is just an amazing asset to have. I'm forever grateful to the parents that I've connected with through social media, community groups. And another amazing thing I learned from a mom friend, and I feel strongly about advocating for, is to find out what resources are available to you out there. Whether it's a family support group, connect with your county or state services to find out what might be available and someone to help you navigate that side of it. And also have some sort of documentation. Make like a little biography or a resume of your kid just to help you keep track of everything that's going on as you move into different, whether it be insurance or school. Aubrey's in the IEP now, and having all this documentation has been so helpful to have who, what, when, where, and why. And lastly, I would just urge families to talk to your family and friends and help them understand your child and what's going on. Lots of times families or people will say, let me know if you need help, or they'll like bring you dinner or something, which is amazing and appreciated. But long-term, for me personally, I want people to know Aubrey and understand her and not be afraid of her or afraid to talk about her. For me to help people understand her diagnoses and even give them like a sample sort of script, like Aubrey had seizures when she was a baby and it's taking her a little longer to walk and talk, or Aubrey has autism and she learns and plays a little bit differently than other kids do. So in my experience, that's been helpful, and it just kind of helps to spread awareness and acceptance. I think last slide, please. Oh, this is her again, starting preschool on the right there. And then the last slide. There's really just so many things that we can't do to help our kids. And I know we all want to just do something, whatever it is. But bottom line, just love your kid, be strong for them. And with anything in life, I feel like just be kind and be brave. And again, thank you for having me here today. I'm getting emotional now. I wish everyone the best of luck and a wonderful holiday season. Thank you.
Julie, thank you so much. Your presentation and sharing Aubrey's story has just been fantastic. And I know you're going to be generating a lot of questions and thoughts in the chat. So appreciate your presentation and your hanging around for Q&A. And Jackie, now I'd like to introduce you.
Hi, thank you. Sorry, I had a little bit of technical difficulties on my side, but I'm now logged into my phone. My power went out because we've had some bad weather here in Maryland. So I am Jackie Steinberg. I'm one of the board members of the STXBP1 Foundation, but I'm also mom to 2 wonderful little boys. One of them, my youngest, is Alex, and he is the one that has STXBP1. And before we had gotten our diagnosis with STXBP1, he did have infantile spasms. So also some little background on me too. I am a nurse, but with nursing school, you're only limited to like what you've learned. And a lot of the people that I had seen as a nurse were adults, mostly with stroke and cardiac. So even with that background, seeing an infant having a seizure was very different. But let me just say, this is Alex. He has, like I mentioned, STXBP1 disorder. It is one of the genetic causes for infantile spasms. And it is like roughly about 1 in 30,000 births are diagnosed with STXBP1, or like about 10 births a day. And it is something that is a random mutation. So this can happen to anyone. Next slide, please. So on the left, this is Alex. We had a normal pregnancy with him, no real concerns. I was monitored. I was over the age of 35, so we were monitored very frequently for a geriatric maternal age. I love that term. But when we brought him home from the hospital, we did notice that he was having these like real stiff movements. Didn't know how to describe it really. We just noticed it a couple of times, like his first day home. So when we brought him to the pediatrician the next day, we mentioned, he's having these stiff movements. And I don't know if it was the way that we had described it. It was just really thought that maybe this was just a typical neurologic development, that the baby was, just brand new, just born. This is something that you might see some jerky movements. But my husband and I took Alex home, and independently, we didn't even talk to each other about this. We started videotaping him. And that is the beauty of today of having cell phones and having a camera. A lot of people have cameras on their phones these days. So we spent a day just videotaping him in different parts of the day of what he was doing, and these irregular movements that we hadn't seen with our other child. And the next day I thought, what I should do, I really should just sit down and watch him. I sat with Alex for like over an hour. I counted how many times he had these movements, and I described them. I noted that, they were irregular. It was stiff movements of the arms and legs, not coordinated together, lasting for about 20 to 45 seconds. And they were in groups. So I would see him have a small break, see him have another one. And he would have these like kind of clusters, but they weren't infantile spasms. They were a different type of seizure. What we were looking at he was having tonic-clonic seizures. Towards that end of that period when I was watching him, I also started seeing that his face started doing twitching. And that's when I started thinking, is this a seizure? I don't know. So I did what a lot of people do. I went to Google and I Googled infant seizure. And the first thing that popped up was actually infantile spasms. And, we went down that rabbit hole of looking at all different types of seizures, trying to figure out what was going on. I called a friend of mine in the medical profession and told her what I was going through. And she just said, listen, Jackie, what's the worst thing you could do if you bring them in? Just bring them in and see what happens. And we did. We took Alex to the emergency room, and he had a seizure right in the triage area. And we were whisked away to the pediatric intensive care unit, and he was having seizures. So it was confirmed he was having seizures, and he was started on IV phenobarbital. And it did stop the seizures from happening. And, we were discharged back home, and things seemed to be going okay. But we did, in that next 6 to 7 weeks, he did end up relapsing off of that seizure medicine, and they've added another one. There was another hospitalization, more EEGs. We had MRI and lumbar puncture to get fluid out of his spinal tap, like a spinal tap. And everything was coming out normal. Eventually he was on 2 different seizure medicines at that point when we first had our first outpatient neurology appointment. And it was at that point, while we're getting ready to go see the neurologist, that we saw the first spasm. And we already knew what it was. We knew. So we just got him packed up, took him to the neurologist. And even though he had just had an EEG a couple of weeks before, he was only 2.5 months at this point. Like, he was pretty young on the age scale of things. Our neurologist listened to us, and we were directly admitted, had an overnight EEG, and diagnosed with infantile spasms. So it happened very fast. It feels like in that time, things go very fast and very slow at the same time. From that point, he was started on high dose prednisone, and after that, he was the things that were described earlier about the things that you experience on high dose steroids was definitely true. He was hungry all the time. Oh, I'm sorry. Next page. Next slide. So the slide on the left side is of him when we were diagnosed, when he was diagnosed with infantile spasms in the hospital. And as you can see, his face started to puff up. He gained a lot of weight in that month-long period while he was being treated. And at that point, we were still halfway through, we're still seeing some spasms. And it wasn't until we had reached that max dose and we had completed the full amount of the max dose right before the taper, and we were talking about the vigabatrin to add that on to his regimen to see if that would help, that we stopped seeing the spasms. And the last EEG he had, it was clear. He had been able to clear this treatment with just that first line dose. We were very fortunate, I feel, in that point. But part of that is having, somebody who was listening to us, identifying the spasms as quickly as we did, because we had the tools in front of us, having the information to explain too, like the videos, and being able to refer back to things that we saw on the internet and say, this is exactly what we saw. It was just like this. It really did help us in getting to that treatment point. So things that I would tell myself, I think if I was to go back, is one, I would make sure to ask for help, because it is that whole period of time when you're feeding and treating your child for that whole month, they're constantly up, and it's exhausting. It really is. As a 2.5-month-old, we were still just in that postpartum stage as well. So it was really just exhausting and trying to keep up with all the feeding. I ended up asking for help from friends and from family. My mom, actually, she dropped everything that she had going on. She moved across the country and moved in with us to help us out with Alex. I was concerned about infection, so I made sure people weren't sick coming into the house, made sure they cleaned their hands. And there was a lot of just monitoring too. Every day we would, as much as we could, we had to get rest, but we'd write down every time we would see a spasm, and we would keep documentation of this. In addition to that, there were other things at the time, we needed to do blood pressure monitoring and blood glucose monitoring. I don't know if that's changed at all, but it did involve having to coordinate with home health and having to get a blood glucose machine and doing all the finger sticks. Fortunately, I was able to do that, but there are some things that, home health was able to help with and to accomplish that. In addition to that, thinking beyond just the infantile spasms too, is it really, when we got that diagnosis, it really kicked me into gear we were on a very long wait list for a genetic counseling session to see a medical geneticist. And I was borderline stalking the medical genetics office, calling them. And we did actually get in an appointment that was, that had been a cancellation. And we got our diagnosis for STXBP1 just at the very end of treatment with infantile spasms. So piling that on, we also had connected with a developmental pediatrician that focused on neonates. They really helped in terms of helping us as an additional resource to find what are some next steps for us, getting connected to early intervention, having someone come and evaluate him, because between the seizures that he had early on and the infantile spasms, he was very behind. He wasn't able to turn his head. He wasn't really able to lift it very well either. So he even at that age, he was still really behind. So it was important to get connected early into these other therapies like occupational therapies and physical therapies, which later developed into feeding therapies and speech therapy as well. And these are all things that we were able to find through our local resources. I think it's important to be able to start that early. And in the case of Maryland, you can actually just self-refer yourself. You can just call the county and ask for an evaluation. Things that I didn't realize at the time. It was not something I was experienced with. So you kind of become your own little advocate, really, because you learn what services are there, what are the expectations for their services, and when to have them come out. The same thing with the genetic counselor. I got on a wait list and there was a cancellation. We were able to get in earlier because of these things. So just making sure, like, being it's almost like being a little a planner for your child, like making sure you've got everything, all the different services listed down and what's the next steps. But really, it was a very emotional time for me as well. So I think also making sure that you are taking care of yourself, whether that means like making sure that you're getting rest, that you're eating. And if you need to see someone to talk, because sometimes it can be really, really scary to think about the future of your child. So really being able to take care of yourself is very important. Just like on an airplane, you can't take care of someone else. The idea is you take care of yourself. You put the mask on yourself and you help someone else. You can't help someone if you can't help yourself. And I think the next slide, I want to just also show a picture of Alex. So this is where he is today. He's 5 years old. He's in kindergarten right now. He is developmentally delayed. He is nonverbal. We are working on different things like speech therapy, though. So we're hoping to, we're being evaluated for, I say we, I say it in we. He's being evaluated for different technologies to help and assist in being able to communicate, and is doing pretty well with those in the trials. So even though he has these disabilities, there's all these things that he has to help with his life. He's able to, he doesn't walk currently, but we're working with physical therapy with a gait trainer. And like this in the bottom corner, he has an adaptive trike that he's trying at physical therapy. On the top right, he travels by wheelchair in the bus. Though he can stand and walk hand in hand, he does have something that he can safely travel in. We worked with our therapy team up on the left-hand corner for an adaptive little vehicle where it has a switch button and he can push it and drive himself forward in his car. And he's just the most wonderful, sweet boy, I would say. Like he is the sweetest, and I love him very dearly. So I would also repeat everything that Julie just said, because what she said is just right on about being an advocate and the resources that you should look at when thinking about infantile spasms. So thank you very much for giving me the opportunity to talk about this.
Thanks, Jackie. Again, really appreciate you sharing Alex's and your family's story on this topic. And again, I think you're going to be generating a lot of growth for people, hearing your story, and that advocacy piece is really important. What I'll do is I'll stop my share so folks can see our panelists. You've generated a lot of great discussion in the chat box. And so some of the questions that I'm seeing, first of all, pertain to medications. And so what is a standard window that, parents can keep in mind in terms of how long can it typically take for a medication to see effect or not see effect?
Well, we've learned that about 80% of the time we should see if response is going to occur. If the infantile spasms are going to go away, they should do so in about a week. So that occurs again about 80% of the time. And then there are a few other responders, that extend into that second week. So somewhere between 7 and 14 days, as I mentioned, we really have to be thinking, okay, maybe this isn't the right medicine. Maybe we need to add one, or we need to use a different one. And so that's what I would say about that. And then there were some great questions in here about if we're thinking about, okay, let's say these standard medications don't work, what do we do then? That's it's a real challenge, to be honest. But I'll tell you, I always think about the possibility of epilepsy surgery. So we're really thinking about, is there a problem in the brain that we can correct with a surgery? And so that should be, top on the list in your thinking. And other possible treatments after standard therapies are ineffective. That might include, Joey had mentioned the ketogenic diet. That's often tried. There are anti-seizure medications that don't have a great track record for infantile spasms, but we do try them. We often do try them. And in fact, in Aubrey's case, it was one of those situations in which there was a response. It did seem to be a nice response to one of these medications. It's hard to know. Maybe the prior treatments had helped as well, and then we continued to aggressively treat. It's possible that we achieve the remission in that way. But yeah, I think we just continuously reevaluate and see, hey, what other treatments could we potentially utilize? We often have to be very cautious, though, about side effects. So we do have to be very cautious about that. And there was a great question about ongoing infantile spasms. You do all these things. Children they're not infants anymore. Okay. And so it's true that infantile spasms, which we think of up to about 2 years old, and then after that we call them epileptic spasms because the children aren't infants anymore. And what we see oftentimes, not always, we often see that those seizures kind of peter out and they're replaced by other seizure types. And then I would just mention to one of these questions in the chat is that the seizures that take the place of infantile spasms often look like infantile spasms, but they may actually be a little bit of a different seizure type. And those seizures, even though they look very similar, even for a time, they can cluster. And so you really have to identify a clinician who's really knowledgeable about those things, who can analyze those seizures and try to direct treatment at them if possible.
Thank you very much. And I think Jackie and Julie, you spoke a lot about, navigating your way through care from your community and, then likely on to larger centers, epilepsy centers. Can you talk a little bit about that? Or does anyone want to kind of touch on the importance of seeing an epileptologist in the journey or getting to a comprehensive epilepsy center if your child is having seizures or ongoing seizures?
Yeah, I guess I would just summarize it as that, it's such an urgent thing to happen. And when you're there for a week, 2 weeks, and the team is just sort of throwing their hands up and they aren't sure what to do, that's exactly not what we were hoping to see for our daughter. So when we were able to get connected with Nationwide, and literally within hours, we had a diagnosis and medication. I mean, it was just literally night and day for us.
Julie.
And for me, we are fortunate that we live in Baltimore, so we have a center already located there, and that's where we decided to go, just based on knowing that they have those kinds of services there. So it wasn't even making sure that we start there and go to a center. We went straight to the center.
Thanks, Jackie. And I'm just trying to make sure.
Yeah, there is a question that I see, Kathleen, and it has to do with vigabatrin. So what we do with vigabatrin is we start that medication and we kind of reassess early, on the order again of 7 to 14 days, looking for a response and then changing treatment if need be. Sometimes we see a partial response. And in those cases, we would want to keep the medication and add something else, for example. And so how long do we use it? Well, if we see we're really convinced that there's been some benefit, whether it resolved the spasms or there's a partial benefit, we will very likely continue that medication for at least 6 months, and oftentimes longer than that. And so it would be common, for example, to use a course that was 12 months, sometimes less, sometimes more. If we really think, oh, this medicine has been really helpful, families say, this is a different child, an improved child on this medication, it would be common for us to just continue that medication for a time. Ultimately, we would try to probably get the child off the medication. The longer you're on it, the greater risk to the retina and the peripheral vision, not the central vision typically, but more so the peripheral vision. And so we remain aware of that and just reassess continuously and assess the risks and benefits of continuing that medication.
Thank you very much. I'm going to reshare my screen just to talk through some resources, making folks aware of the Epilepsy Foundation's 24/7 helpline. We are here to assist you in, getting questions answered, helping you find providers. I know Alyssa put into the chat for folks, if you're looking to find where you can seek epilepsy treatment in your area that's local to you, epilepsy.com has a Find Doctor tool that is, available, and also our support team on the 24/7 helpline, available in English and Spanish, are able to help connect you with where it's local to you. The other resource that I definitely want to mention is the Rare Epilepsy Network. Julie and Jackie both spoke about the importance of parent communities and caregiver and support. They are a really great resource in terms of connecting with your community and asking those questions. As I think, Julie, you had mentioned that those were the folks that you could find on Facebook or, at all hours of the day or night, and really lean into that resource. So thank you to the REN who also supported this webinar. We really would like to continue improving content that we're bringing to the community around the epilepsies, and for this session in particular on infantile spasms. If you can please, we'll be sending around material after the session containing this link for your feedback in our survey, and so please consider completing this. It's how we consistently improve our content. I'd like to mention that this session is being posted to Epilepsy Foundation's YouTube and will be available in the coming weeks ahead. And lastly, I'd like to thank our speakers, Dr. Mytinger, Julie Oberlander, and Jackie Steinberg, for your unbelievable contributions today and sharing both a clinical perspective and the lived experience. Thank you for your time today. So with that, I wish everyone a great rest of your day and a great holiday season, safe, happy, and healthy for you and your families. Thank you again. Take care.